Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison. It's my pleasure and privilege to serve as the host of the CGNE Seminar Series. And I want to do a shout out to Jenny Rank, our CGNE Education Program Specialist, for all the work she does to support this series as well. The program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar is entitled Enhancing Preference-Based Person-Centered Care for Older Adults with Multiple Chronic Conditions via Implementation Science, and it will be co-presented by Drs. Katie Abbott and Kimberly Van Haitsma. Before we begin the seminar, I want to take this opportunity on behalf of the CGNE leadership team to congratulate Dr. Abbott on being named Executive Director of Scripps Gerontology Center at Miami University of Ohio. We are super excited for you, as well as for older adults that will benefit from the expertise and the great work of your center. And we look forward to collaborating with you more in future years. So next, we do have some disclosures and announcements to make. Thank you, Jenny. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continual professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn 1 contact hour. Partial hours are not awarded. The topic of this education is non-clinical, and therefore we did not mitigate, identify, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed. As a reminder, this seminar is being recorded. If you have any questions or comments for our speakers, we will address those during the Q&A and discussion portion of the session. And please enter those into the chat feature. You can also raise your hand if you'd like to be unmuted and ask your question or share your comment aloud. The post-event evaluation survey link will be placed into the chat after the presentation. It will also be emailed to you within 24 hours. Again, this is required for RNs seeking contact hours, but we do ask that all attendees complete the evaluation to assist with data collection related to Age-Friendly Care PA, as well as provide important feedback to us about the seminar series itself. Nurses will receive certificates with their contact hours within a month of the seminar. And if you have any questions at all, you can reach us at cgne@psu.edu. Next, I'd like to reintroduce Nahida Akhter, one of our CGNE graduate PhD student affiliates. She's highly engaged with our center and college. In addition to her graduate studies, Nahida takes on additional responsibilities and activities such as serving as leader of the doctoral student organization this year and participation at GSA in November. Nahida is an exemplary student, and we're thankful for her to introduce our speakers today.
Thank you, Janice. Dr. Katie Abbott is Executive Director of the Scripps Gerontology Center and a Professor of Gerontology at Miami University in Oxford, Ohio. Her research and teaching focuses on preference-based person-centered care and the social network and health of older adults receiving long-term services and supports. She is the co-founder of Preference-Based Living, whose mission is to conduct studies that build understanding of individual preferences and test innovative methods to honor preferences for people receiving long-term services and support. And we have Dr. Van Haitsma, Dr. Van Haitsma is a clinical geropsychologist with a PhD in clinical psychology. She is professor in the Penn State Ross and Carol Nees College of Nursing and director of the program for person-centered living systems of care. She also serves as adjunct faculty department of Human Development and Family Studies. Faculty affiliate in the Center for Healthy Aging and adjunct research scientist at the Policy Research Institute, Abramson Senior Care. Dr. Van Haitsma areas of research include development and testing of various mental health education and intervention approaches, innovative methodological and measurement development and testing intervention and implementation strategies that facilitate the uptake of evidence-based, person-centered, preference-informed care practice targeting older adults with multiple chronic care conditions. So let's welcome them. Thank you.
Thank you so much, Nahida. Can you all see my slides? Can you see the slides okay? Great. So we're just delighted to be here today and spend a little bit of time chatting with you about some of the work that Kimberly and I have been doing over the past few years. I do want to acknowledge, we don't have any financial disclosures, but I did want to acknowledge that Miami University used to be the homelands of the Miami and Shawnee people. And so obviously we all know that they were forcibly removed from the land that the university sits on. But what I also want to call attention to is the incredible work that we've been doing with the tribe lately. And since 1991, we have been engaged in making sure that individuals that belong to the Miami tribe of Oklahoma are able to come and get an education here at the university. We have an active Miami Center that engages in doing a lot of research and support of the tribe. And so it's something that we're very proud of, that we wanted to disclose as well. And so at this point, we'll turn it over. I'll turn it over to Kimberly to give us a little overview and background.
Thank you, Katie. Again, Katie, I have to kind of laugh when you say a few years we've been working together on this. We have this work that we're going to show you today is a taste of different aspects of the work that we've been doing probably for about 15 years now together. So for the students in the in this seminar, again, just this gives you sort of the longer view of what work kind of can evolve and look like over the course of a longer period of time. And so we're going to give you, again, just a taste of some of the both scientific types of issues that we've been working on, introducing you, perhaps new to some, perhaps old to others, some frameworks that we found very helpful in looking at this issue of enhancing person-centered care, as well as just giving you a sampling of some of the very specific evidence-based approaches that have emerged from our implementation and intervention work over many years. So just to start off, we can say, well, why should we be looking at person-centered care for older adults with multiple chronic conditions? And our focus has been on people living in nursing homes, not exclusively, but a lot of our work focuses around people living in nursing homes because they are the most vulnerable, clinically complex of older adults and have the highest care needs, and therefore are perhaps the bigger challenge in terms of delivering person-centered care in light of those complex needs that they have. And I find it very encouraging that even in the last year, we've seen a couple of national initiatives that have come out. We're giving you two examples of the focus on why preferences in particular are important in person-centered care. The National Academies of Science, Engineering, and Medicine put out their National Imperative to Improve Nursing Home Quality report, and we do reference this at the end. If you guys have not seen this, it's a great overview, as well as a recent report that has come out of the SCAN Foundation, which again is looking more broadly at improving care for older adults and looking at reimagining care. So this dialogue around reimagining care for older adults to be more inclusive of person-centered care is really emerging as a national topic of interest. And a central component of that discussion remains how to make it care itself responsive to people's preferences. So next slide. So in that regard, I believe it was Kurt Lewin who said there's nothing so practical as a good theory. And so we're going to start you off with some discussion around some of the theories and frameworks that we found particularly helpful in our work around person-centered care over the years, starting with the Donabedian model of for quality of care. And basically, this model says that for healthcare delivery to be of high quality, any intervention or approach needs to consider these three elements: structure, process, and outcome in relation to whatever it is that you're developing. So in relation to person-centered care, we've certainly looked at each of these elements as we have looked at some of the care approaches that we've been developing. Next slide. Another very formative framework is the age-friendly, the Institute of Healthcare and the Improvement for Healthcare Institute is their age-friendly healthcare system model of what matters: medication, mentation, mobility, better known as the 4 M's. You'll notice here that within this framework, the idea of what matters really drives everything else in terms of care delivery that follows and flows from that. So knowing and aligning care to each older adult's specific goals and care preferences help with the clinician's decisions around what to do with medication, mentation, and mobility. Next slide. So on a more practical level, person-centered care systems must be inclusive of these types of elements in order to get uptake of evidence-based practices in these care arenas. And that is that we need to have evidence-based training types of opportunities for the staff that's delivering that care. Assessment, of course, is a central piece of any clinical intervention. How do we understand, in this case, what's important to the individual, what their preferences are, incorporating that information into care plan and communicating with diverse teams around the person's preferences for care is another central step. And then actual aspects of delivery of that program with a step-by-step process that we want to make sure that we have fidelity to as people are using the types of care approaches that we're developing, as well as using evaluation and outcomes that are meaningful to not only persons living with dementia, but also their caregivers. So and care partners, and keeping that in mind as we are sort of looking at each aspect of the types of things that we're developing around person-centered care. Next slide. So from switching to a more theoretical framework now and theoretical approach, we've also sought to sort of look at this issue of what is preference-based person-centered care and what are the mechanisms involved in going through all that effort of delivering a person-centered care approach. Why should that result in better outcomes for people who are receiving that care? So this really is our hope in advancing the science in this area, which has been very vague on this notion up until this point, because it is a very complex issue, starting with even just the words that we use. So the idea that we focus on using the word preference, but when you look at the literature, you will find words like needs and values and goals of care. And so we have done some work within this article that you see here to sort of help start disentangling that. So the next slide gives an example of how we go from operationalizing these types of words that are used in referring to preference-based person-centered care, all the way starting from a specific example of a preference, which is the most concrete representation that is important in the care delivery process. So, for example, how important is it to you to choose your own bedtime is the preference. And then the need that preference is linked to or represents is autonomy. The goal might be something to the effect to make one's own decisions about how much sleep is deemed personally necessary for their optimal functioning. And then the value system that this represents is the idea that control is an important element and that is valued by an individual that might have this particular preference. So here you can see how we kind of went through and looked at the various aspects of how preferences can be tied into these broader literature discussions around needs, goals, and values. So next slide. So this is just a theoretical framework that you'll see in the paper that I mentioned. And again, this is an attempt to sort of tie together several different theoretical frameworks within gerontology that have been influential in thinking about how we think about the everyday life of a person, an older adult, and how we can use interventions to help optimize that everyday living and functioning for an older adult. So the very top bar, which is environmental press and person attributes with fit in between, is the person environment fit theory of Lawton and Nahimo, who were a grandfather and grandmother in many ways of gerontological theory around how to understand both the impacts of environment for a person in the context of experiencing declines, like for example, if someone might have dementia, how those functional and physical and cognitive attributes declining over time might be compensated for by the environment, as well as just an acknowledgement of the social and cultural and political context. So again, referencing back more toward sociological theory and understanding that our care does not take place in a vacuum, that it definitely is influenced by these larger forces. And then again, you'll see sort of the expression of our preference work in there, going from preferences to goal-directed behavioral approaches to outcome. And again, the goal-directed behavioral episode you see here is from living systems theory, which is again describing how people operate, how our behavioral psychological composition operates when we are asked to engage in a behavior of some kind, and the reflection that behaviors are always goal-directed in some way. So this idea that the outcome that we're looking at we could put many different outcomes in this particular box. Well-being is sort of the broadest one, but we use also the example within this article of a particular outcome called affect balance, that we also have several, I think at least one article in here in the references for you to consider, which is basically the idea that emotional well-being is particularly important for older adults, and that the idea that the balance between a positive emotional experience and a negative emotional experience is in the positive direction. So we want to make sure that simplistically how this is referred to is that we want to make sure people experience more smiles than frowns over the course of their daily life. So finally, the next slide, we focus a great deal of our work focuses around measurement and the development of really practical tools to approach how the person-centered care might be leveraged into these dynamic resource-limited care environments, such as a nursing home. And the examples that Katie will be giving, I think, are derived from our work within the nursing home. And this is widely referred to as addressing the issue of we treasure what we can measure. And so the idea being that if we can't measure it, we can't describe what it is that we're trying to accomplish or to get people to utilize, and what goals we're striving toward, that we are not going to make much headway. So you'll hear in Katie's next explanation in terms of why we really focused around measurement issues in particular. So Katie, I'll turn it over to you.
Thank you. And that was a wonderful context and backdrop to what I'll be talking about. And so many of you have probably heard us talk about the Preferences for Everyday Living Inventory, or PELI for short. And this has undergone extensive testing. And it started out in a sample of over 550 home health recipients, and then was revised for nursing home populations using the voices of over 350 nursing home residents. And what's important about that is it seems silly, but the way the questions are worded was guided by the voice of the older adult. And again, it seems like, well, yeah, that should be the case, but that's not always been the case in research. And so what we're particularly proud about is that older adults guided the choice of words that we used here. And we kept asking, once we sort of had, okay, well, these were all the things we could come up with. What else might we be forgetting? And they would tell us. And so again, the full scale, there are 72 different standalone items. It's not a composite scale. Each item can stand alone, and that can assess a variety of preference domains. There's a response option to it, from not at all important to very important, because we wanted to make sure we could guide quality improvement. And without having an understanding of how important something is, we were struggling with, well, how do providers focus their scarce resources? And so the idea behind this is that care team members can use the PELI to learn about the important preferences of their residents. And our website, I'll put some of this in the chat too, but our website has a lot of our resources. And so we'll direct you to that. This is just a sampling of some questions so that you can sort of see how the PELI is laid out. And so, for example, how important is it for you to choose to get up in the morning? And what you can see here is that if it's important, it's also helpful to know, well, okay, what time would be good for you to get up? And that's what goes into the plan of care. If it's not important, you can move to the next question. So for example, how important is it to you to have regular contact with friends? Again, if it's important, well, we need to know, who are those people? How can we support those friendships? And if it's not important, again, we move on to the next question. How important is it to you to have staff show you respect? And this is sort of a little bit of a trick question, because everybody wants to be shown respect, right? However, the way I want to be shown respect may differ from how Kimberly wants to be shown respect. And so understanding the nuances around what respect means is important to understand here with this question. And the final example I'll give you is from the minimum data set, or MDS 3.0, that we'll talk a little bit more about. How important is it to you to listen to music you like? Again, this could be important for everyone, but don't give me the 80s, hairband music, give me the 80s pop music. So you need to know what kind of music is important here. Lots and lots of providers use the PELI. We don't really have a specific number. We've been trying to measure it here in Ohio. It's in the hundreds. It can be administered by a variety of people, professional and paraprofessional teams. Before the pandemic, a lot of volunteers were using it. We developed some training videos around how to interview using the PELI that were 20 minutes long, so that if a provider community wanted to train some volunteers to administer the PELI, they could. It's recognized by many national organizations. As I mentioned, as part of the MDS 3.0, there's a section F around preferences for routines, and the PELI heavily influenced the development of that tool. We have done extensive research on reliability and validity of the PELI. One thing that we know is important is that providers have very little time. We wanted to be able to say, okay, is it worth your time to ask these questions? Are they going to be the same a week from now, 3 months from now, a year from now? And we've been able to say yes to all those questions through our data. We've been able to say that yes, preferences remain relatively stable after a week, after 3 months, which corresponds to the care plan conference in nursing homes, and at a year, which is typically when preferences are reassessed in the nursing home setting. Now, we do also know that there are some reasons why preferences do change, and those may be because of the person. It may depend on their interactions with other residents. It could depend on the interactions with staff or even things outside of the nursing home environment, like the weather, like the political environment. And so, those are things that we do understand where it depends comes into play. We have developed resources on how to incorporate this information into the plan of care, how to use these tools in quality improvement. And we have over 30 peer-reviewed articles stemming from work funded by multiple groups and organizations, the NIH, specifically NINR, the Alzheimer's Association, the Donahue Foundation, and the Ohio Department of Medicaid has enabled us to put forth much of this work. And again, having grant support means that people believe in your ideas, they believe in the work that you're doing. And so we feel very fortunate to have been able to steward these resources in this way. The 4 buckets or domains that we think about in terms of the work that we do come under assessment, integration into care, communicating those preferences, and then how do we evaluate things. And so we obviously want to encourage providers to use the PELI to assess preferences. And again, they can pick from whatever items. They could start with the MDS 16 items, or they could pick, maybe they're challenged with meals and snacks. They could pick the 6 items related to snacks and meals to focus on. Again, for quality improvement purposes, it needs to be a small amount. You can't really do quality improvement on 72 different items. We help in them integrate important preferences into the plan of care and have resources on how do they create care planning meeting or care plans. How do they then evaluate? Are those preferences being met? How do they think about that at a quarterly care planning meeting? We have some resources on communicating those important preferences across different individuals, different shifts, different departments. The nursing home environments are very dynamic, and so it's challenging to communicate information. And then we also help them think about tracking and documenting their progress and preference fulfillment and satisfaction. Well, for me, I came into the implementation science sort of just by accident as to what happened. Kimberly had been involved in this a little bit more. And so I'll tell you a little bit about implementation science, and I'll tell you sort of how it just kind of was an opportunity that presented itself here in Ohio. So there was a study done that indicated that it took 17 years for an evidence-based practice to get into practice. And so there was this recognition that that's way too long. If we know something works, why is it taking 17 years for us to get it into practice? And so there's this recognition of the gap between what we know and what we're actually doing. And so we think of it as this no-do gap. But implementation science is the scientific study of methods and strategies that facilitate the uptake of these evidence-based practices. And it seeks to systematically close that gap, that 17 years. Can we do it faster? And so by identifying facilitators and barriers that help implementation, we can get that uptake of those evidence-based practices to happen much faster. Thinking about implementation science, there's lots of ways to think about it. So this is a helpful resource and tool that we've referenced here for you from Jeffrey Curran. If you think about the thing as our preference-based care, so the intervention, practice, or innovation is preference-based care that we're talking about. Effectiveness research looks at whether preference-based care works, right? So if I receive more preference-congruent care, am I going to have better outcomes or not? Implementation research looks at how best to help people do preference-based care. Strategies are the things we do to try and help people or places implement and do preference-based care. So here's the tool. Here's how you write a care plan. Here's how you communicate it. And the main implementation outcomes are how much and how well are they doing preference-based care. So that's another way of thinking about it. You could insert your intervention that you may be developing there. We have an article that was published last year around why implementation science, and particularly in nursing homes, they're just a unique environment. Very little research has been done around implementation science in nursing homes. We know they have different resources, different workflows than other settings of care, such as acute care and hospital type environments. And what we find is that if we can use implementation science strategies and frameworks, we can get towards more equitable care. And so with all of the initiatives around diversity, equity, inclusion, implementation science is one way to systematically lead that effort. So this was what I mentioned where I kind of fell into implementation science. I had been working with Kimberly out in Philadelphia, took a position here at Miami, moved out here in 2014. And in 2015, the Ohio Department of Medicaid decided to implement the PELI as part of a pay for performance initiative. It didn't consult us, didn't even know about it. We kind of found out by accident when I was presenting at a conference and somebody blindsided me with the question about it. And so then this was a way of, so policy is an implementation strategy. I wouldn't say it was a really good one in this instance, only because of the way that they implemented it. And so that was a little bit of a struggle. And we detail all of this in this paper that you see here on this page. And again, we've got a list of references at the end. And so because this emerged, there was this sense of urgency and a motivation by providers in terms of why they should be interested in preference-based care. And so that helped lead us towards developing a lot of our resources. And so we applied for a civil money penalty grant through the state of Ohio and were funded to do some of this awesome work. The approach we took was is to sort of think about how do we support staff in a feasible way where they can learn about individuals' preferences and communicate them over the course of a day or a week, where you have a workforce that we all know is plagued by high turnover, especially during the pandemic. And workflow changed. People weren't allowed to go into certain rooms. There were restrictions and quarantines. And so, as I mentioned, we've received 2 civil money penalty grants to develop these tools to address these problems and to work with providers on testing through quality improvement strategies. And it's been very, very rewarding, I feel. So the couple of innovations I want to mention quickly to you today. One are called our Preference for Activity and Leisure, or PAL cards. And think about a 5x7. I actually have one I'll show you in a minute. It's a 5x7 laminated card. On the front, first name, short bio, backside, space for some important preferences. This can be placed on a walker or wheelchair or door. This grew out of a provider that we met with who said, I just want to be able to communicate preferences like a card X on the back of a wheelchair. And so we worked with them on proof of concept. And that's where we really find our sweet spot, is that we love to hear about the barriers nursing homes encounter. And then we have the students and the resources to problem solve and to figure out resources. And we can try these proof of concept and come back to them and say, okay, well, what about this? And what about this? And iterate in a very agile way. The second innovation is our IPI, or Individualized Positive Psychosocial Intervention. And this is an evidence-based program that engages people living with dementia in brief, think 10-minute, one-to-one preference-based activities 2 to 3 times a week. And in a hybrid type 3 randomized control trial, we found that people living with dementia had fewer negative emotional and behavioral responses when receiving the IPI compared to those receiving usual care interventions. Here's an example of the PAL card. We have a paper that's out about this, that's open access, that again is in the references. So you can see we've got a name, a little bio, and we've got 6 important preferences here. And one thing is that we also worked with some speech language pathologists to understand communication preferences, right? So how should I be communicating with this person? So you can see there's some icons in the front here that refer to the communication icons or the communication preferences on the back of the card. And so this was a recent innovation that we're really proud of. Here's some PAL cards in action. You can see them hanging on a wheelchair, a walker, on a door. Again, communities can decide where these might best live. Here's some examples of IPPEs in action. They're a little bit harder to show because it's a one-on-one activity, but think about having somebody who's always preferred to play music and listen to piano music, being able to sit down with somebody else and play the piano for 10 minutes. Okay. So how did we use implementation science frameworks? As I mentioned, we wanted to understand the barriers and facilitators to the implementation process from the provider point of view. We needed them to do this work and tell us what are the barriers they face. And then that would help us identify what we should be paying attention to. And it also helped us know what we should measure pragmatically to advance the science. And we have sorry, I forgot to include the year on that, but I do have it at the end of the slides. In terms of trying to understand the acceptability, feasibility, and appropriateness of both our PAL cards and our IPPE interventions. The CFR, or Consolidated Framework for Implementation Research, I know it's a mouthful, this has been invaluable to us. It has helped us understand the different domains we should pay attention to. And I have another slide here that explains it a little bit more, and then I'll give you a couple of examples that we've used. So it helps us understand, well, what is it about the characteristics of the intervention that either make it easier or harder to implement? And you can see there, we have intervention source, evidence, strength, and quality, relative advantage, adaptability, trialability. Then there's inner setting. So what is it about the nursing home setting that makes this either easier or harder to implement? And there you can think about networks and communication, culture. You can think of an organization that's very person-centered, maybe having fewer barriers than an organization that's more medically model-driven. The outer setting is another domain that we think about in terms of the patient needs and resources. We all know that the acuity is getting higher and higher in nursing homes. Peer pressure. What does it look like if you have competition in the marketplace? The individual involved. So this is about the characteristics of the individuals who are doing the implementation. So their knowledge and beliefs about the intervention matter. Their confidence or self-efficacy in implementing the intervention matters. Where they are in their stage of change matters. Much of the CFR comes from the Rogers diffusion of innovation, if you're familiar with that theory. And then finally, process. What are the processes involved that help facilitate or hinder implementation, such as planning, engaging, executing, and reflecting and evaluating? So I just want to give you a flavor of what a few of the providers have said to us. So thinking about the characteristics of the intervention, the PAL card in particular, relative advantage is the advantage of using PAL cards versus an alternative. Many folks don't even have an alternative around this. We've done different things over the years, like care cards and different things, but I think this kind of centralized the information and made it easily accessible for people to see. I do definitely see the benefits when it comes to new staff, ones that haven't had a chance to get to know the resident yet, and as well as agency staff, meaning temporary staff, if you're not familiar with that term, that could be in and giving the care because they haven't had the time to build that relationship. So any information that you can give them helps. So again, an example from the provider around how the PAL card is better than other things that they've done. Another example for inner setting. This is around champions using existing communication channels to inform and educate staff about the quality improvement project. We have an employee newsletter that goes out the first of each month. So in that, I'm going to kind of explain what the cards are, and everybody will know what they are. Won't just be some random piece of paper stuck somewhere. When we were doing pilot testing and proof of concept testing, we didn't tell the champions to specifically educate all the staff about them. And guess what? Nobody read them. They just ignored them. And so we knew that needed to be an intentional effort. We've been taking advantage of the staff coming in for COVID testing twice a week. So we've been doing like 5-minute sessions, or if it's a lengthier topic, having them after they leave their testing area to go to the dining room and educate on topics there. So this is how they were trying to inform staff about PAL cards and why they should read them, the purpose of the cards, and how the cards can help them do their job more efficiently. Thinking about the characteristics of the individual Another example, characterization of the phase an individual is in as he or she progresses towards skilled, enthusiastic, and sustained use of the intervention. That's the C for definition. So the quote that came from a provider, so that's pretty much where we are. I'm not disappointed in the process. So far, I'm not disappointed in where we are. I really had hoped that I would have gotten a better response from family members and the resident representatives, especially for the ones who are not able to express themselves. But you know, here again, sometimes you have to chase family down the hall and around the block to be able to get what you need. So again, thinking about the stage of where that individual was, the types of folks, and this leads a little bit to the outer setting too, right? That the involvement of the family in that care community. And then finally, I always want to tell you a little bit about process. So champions that had a plan of action before implementation were more successful than champions that did not have a plan. Big surprise there, right? I think that just rolling it out, it took more time initially, but like going forward, I have it on the calendar where I set aside time to either interview residents, new residents, create their cards, you know, whatever the case may be. But now it's already established. It'll be much easier going forward to continue it. In terms of engaging staff and family was a crucial part of successful implementation. I think you have to have staff that are willing to do it and wanting to grasp the whole project, you know? So we're very lucky to have a good team. We definitely had to call family because we can't do anything without their permission. One husband, and I explained to him, I showed him a sample and he said, oh, I think that's a good idea. And then finally reflecting and evaluating. So taking the time to pause and reflect on the implementation was helpful for champions to better understand the process. What was interesting that once you got the STNAs on track, and that's CNAs, they're called state tested nursing assistants here in Ohio, then their big thing was you need to get everybody and more people need to have these cards. I said, yes, there's a process we have to do, but don't worry, we're going to continue this. And it was nice. It was like, there should be more people in this, you know? I get in this room and there's no one in there that had that room, you know, and they don't know, they don't have that card. It was nice in the end, you know, and they know we're continuing to do it. So it's nice. More people need these cards. So the next steps in terms of where are we moving, we've recently received funding through the NIA Impact Collaboratory, and this is super exciting work. If you're not familiar with the Impact Collaboratory, again, we put the link on the slide for you to check them out. It stands for Embedded Pragmatic Alzheimer's Disease and Alzheimer's Disease-Related Dementia Clinical Trials Collaboratory. The idea here is to build the nation's capacity to conduct pragmatic clinical trials of interventions embedded within healthcare systems for people living with dementia and their care partners. And so we've received funding from the Impact Collaboratory to work with a provider community called United Church Homes. We're going to be working in 9 of their nursing homes over the coming year to understand, we're going to talk to them about the IPI. We're going to talk to them about some outcomes that we should be thinking about. The goal is for us to talk to residents, family members, direct care workers, director level folks, IT staff, and what we hope is to be able to come up with a list of outcomes, maybe process and outcome measures that we need to pay attention to, and then build a user-defined assessment in point-click care that can be tracked in a pragmatic way. And then that can lead into the next phases in terms of a pilot, an embedded pragmatic clinical trial of the IPI intervention. So this is really work we're really excited to just be starting. As I mentioned, I'll put some links in the chat. But many of our resources are at preference-based-living.com. We have tons of resources and they're available at no cost to providers. We're also on social media. Please check us out on Facebook and Twitter, subscribe to our monthly newsletter. And we just want to stop here and say thank you to all of you for your time and attention. I'll turn it back over to Janice.
Well, thank you, Kimberly and Katie, for such an outstanding presentation and sharing some of the breadth and depth of your work on preference-based care. It's just extraordinary and so important for all of us to learn about and how it relates to implementation science is also very interesting. So thank you for for sharing all of that important information. Before we begin the Q&A discussion part of this seminar, I want to invite all participants to complete the evaluation tool. We'll just pause for about 3 minutes to allow you to do that. The link to the evaluation tool has been placed in the chat by Jenny Rank. So please copy and paste that, or I think you can even click on it and take just a few moments to complete that. As a reminder, it's required for all RNs seeking 1 contact hour, but we do ask that everyone complete it to provide us with some feedback and data. We also remind participants that another requirement is to attend the full session. So please join us in just a couple minutes for the Q&A and discussion.
And Janice, as they're doing that, I'm popping links into the chat. So these are some of our references. I don't have all of the active links to all of our references, but with that, Jenny, will the slides be sent out to folks to get it, or should I?
I typically send them out if people reach out to me and ask for them.
Awesome.
But I can compile everybody who attended today and send it out to everybody. That would, if you're okay with that.
Yeah, well, I was just gonna say, I'll just keep posting references in the chat. Then that way they should have what they need, but absolutely, please reach out. I'll put my email in there too. Please reach out if you have other questions.
So it'll be important that we save the chat if possible, Jenny. That'll be great. Thank you.
And it's just the last slide of our presentation. And so if you don't, it's all there as well. So don't feel like you're missing anything. I'm just clogging up the chat right now.
And as people are completing the evaluation tool, and after Katie stops clogging up the chat, we'll invite people to put comments and questions in there as well. I'm seeing a lot of really positive comments about the presentation itself.
All right, I'm done.
Okay, nope. She's done clogging. We're unclogged now. Okay. So I'm going to go back through and make sure I didn't miss something earlier. So lots of positive feedback about the presentation. Fantastic, great, wonderful presentation.
Looks like Diane has a question.
Diane is asking, do you have suggestions for students or early career researchers who are looking to develop partnerships with long-term care providers, policymakers, or other outside partners, as far as establishing and nurturing these crucial collaborations that are needed to engage in this type of research?
It's a really good question. You want me to take it first, Kimberly, or you want to take that one first? So my experience is that there's no one strategy. It's just you have to continually show up. You continually show up and you serve on advisory boards that you interact with providers. You present at conferences where they go. You say yes when they ask you to serve on their boards. You say yes when they reach out to you with information and ask you to speak someplace. You know, not only is there turnover in the nursing home staff, but these leaders turn over too. And so I see it, there's just constant need for outreach, especially with policymakers here in Ohio. Every time an administration changes and turns over, we're back knocking on their door to tell them about the Scripps Gerontology Center and all the great work we do, because it's just the nature of the beast. So I can't say there's any one strategy. It's just, I think, a commitment to continuing to do it all the time. Kimberly?
Yeah, no, I would agree with that. And I think, you know, some particular in relation to person-centered care, because again, you know, some of the literature out there suggests, of course, that there's a minority of nursing homes that are actually able to deliver true person-centered care. but there's a great desire among nursing homes to gain their competencies in that area. And I think connecting with provider organizations that have some competencies in this area, for us, it has been the Pioneer Network that has been particularly helpful to form collaborations with. We go to their conferences, we present at their conferences, and they have a lot of sophistication and connection around person-centered care. Each state has a coalition, a state level organization related to the Pioneer Network, and Katie and I have used extensively the one both in Pennsylvania and in Ohio to help us in terms of thinking collaboratively and partnering around development of some of the work that you're seeing here. So again, I think finding out who those organizations are that have, like the Pioneer Network, the Dementia Action Alliance is another very wonderful group. Yep. That they have good giveaways at their conferences is something to I think that is very, very valuable. More pragmatically also, I think that if you have nursing homes near you that are part of chains, that can be particularly helpful to get in and work, offer to present, come on in and, make yourself known, which I think the CGNE has been just fabulous with here in the State College area. And that also can help you then build those relationships that allow you to, you're going to need typically more than one nursing home to be able to test out proof of concept types of things. And so, using those types of relationships within nursing homes that have more than one in their portfolio is also very helpful.
And build in funds for these organizations. So for example, in some of our grants, we have like a $300, payment to an organization. Let us come present we give them 10 minutes of a research presentation, and then we get their feedback on how do we make sense of this information? How do we disseminate it? And then we pay them $300 for that. Or you pay the individual for that. So build in money for your stakeholders into your budget. And that can be extremely beneficial because most of the organizations that do this are volunteer based. They have no real source of income. There's not really a paid staff person. And so that helps grease the wheels a little bit too.
That's an excellent strategy. Thank you so much for sharing that, as well as all the information. A couple of related comments. Donna Fick is saying DAA has been a great partner for acute care and community work as well. And Liza Behrens mentions that the Pioneer Network conference this year is being held in Pittsburgh. So what a great opportunity for those of us at Penn State to participate this year. Donna also had mentioned fabulous presentation. She does need to log off at some point for another meeting, but wondered if you have been in touch with IHI and Alice Bonner to share this work, as they have a growing number of nursing homes in their action communities. And she's also going to a nursing home meeting today and would love to see them use this as well.
It's a good reminder. We haven't reached out to Alice lately, and so it's a good reminder to do that. Thank you for that, Donna. Yeah, that's great.
Yeah, and Alice was very involved early on in helping us from a CMS perspective, helping to get some of these when we've developed many, many more materials since then. But she's terrific, and that is a good suggestion, Donna. Thank you for reminding us of that.
One very specific question I had for you that maybe I know some of the answers to this, but I think some of our audience may want to know a little bit more too, is in relation to the Peli instrument. It's 72 items, and you mentioned that it can be done as a standalone assessment or that portions can be done. I'm wondering if someone was to implement the full assessment, how long does that typically take, interviewing a resident or an older adult? And can it be done in segments? because sometimes older adults, especially those living with dementia, can get a little tired. And then as a follow-up question, once you've done the assessment, it's probably a wealth of information. So how do you select which items to prioritize in terms of care planning?
Really, really good question. You want to take that first, Kimberly, then I'll do it.
Yeah, so I think that we have had many providers who have done the full 72 items and elected to do that, and takes, well, there's a great deal of variability around how long it takes if you sit down in one setting to do it, about an hour, but we really recommend not sitting down in one setting to do it. And we do that for a couple of reasons. One is the reason that you suggested, which is that, you know, it's better to break things up over time because the people get fatigued and, you know, can't sit for those long and attend for that long period of time. But the other thing is that it helps to emphasize that this is a process. This is a relationship building opportunity. It is not a task. And we don't want people to think of it as like, oh, I'm going to sit down with this person, check off the box, you know, it's done. And now, whew, thank goodness I'm done with that task. But really, it's this process of getting to know somebody and over time and saying to people, you know, maybe I'll ask 3 questions, you know, while I'm helping them, you know, get ready and get dressed in the morning. And then I'll ask another 3 questions, you know, while I'm, you know, walking the person to lunch. I mean, so that type of idea that we're really encouraging people to use this as a relationship-based opportunity to interact, develop a relationship as opposed to a task to sort of check off all of that.
I love that mindset about it. I love that framework, you know, that it's about relationship building and getting to know the person as opposed to checking off the 72 items. Yeah.
Mm-hmm.
And we would also have them ask them to prioritize before they start. So look through the 72 items. What items? Maybe there's 10 that really speak to the mission of the organization. Maybe that's where you start. Again, doing all 72 may not have as good of a return on investment as just focusing on a handful. And then
that could even relate to their QAPI process.
Absolutely.
You know, what are they working on as an organization in relation to quality improvement? So where do they want to focus their assessments?
Exactly. We've had organizations come to us who are taking their family or resident satisfaction scores to heart. And they're saying, look, we didn't score very well on move-in. How can you help us improve our move-in policies and procedures and process, right? And so coming with a very specific, you know, idea around how they'd like to improve is a great way to start. And then you're starting with a smaller number. It's not as heavy of a lift, right? The learning curve isn't as steep. And they can try and utilize that information right away. And we haven't even talked about Compass, which is our software program that helps providers ask the 16 MDS questions, follow up with satisfaction, gives them a little pie chart around how they're doing, and then gives recommendations about IPIs they could do with individuals for areas where they're not doing so well. And so that's a whole nother you know, ball of wax that we're trying to develop and get moving. I can put that link in there too if people are interested.
Yeah, the tools and resources you've developed based on your research and your work, it's just incredible. I'm familiar with some, but you continue to flourish in that way. And you shared the PAL cards as one way of communicating. I think that's one of the biggest challenges, you know, having been a former director of nursing, knowing that, you know, one individual aide might know something in particular about a resident, but sharing that information across shifts and departments with people that need to know it. So can you speak a little bit to the use of the PAL card? And I know one of the concerns I've asked about before is, you know, sharing confidential or individualized information visibly on a wheelchair, for example, and how does that relate to, you know, regulatory standards, that kind of thing? And are there other strategies that you recommend related to communicating preferences amongst staff?
Great questions. Yeah, so HIPAA compliance is always a concern that providers have. And that's why we chose to start with the preferences for activities and leisure. And every HIPAA privacy officer I've ever spoken to has said that preferences are not protected health information. So there's those 21 items or so that are protected health information. And so we don't want them putting birth dates or room numbers or Medicare numbers or diagnoses on the PAL cards. But if they stick with just biographies and preference information around activities and leisure, you can't go, there's nothing in terms of HIPAA. Now you could have what you're mentioning also is like a privacy issue. Maybe somebody doesn't want that card placed out in the open. And so if the individual is able to communicate, asking them, where would you like this to live, is a great way to do that. And if the person can't communicate, maybe talking to a family member or putting it in a discreet place, like on the inside of a closet door, and just making that, systematic across the organization so everybody knows where to look. Because that's one thing you want to avoid is trying to like search around for the card.
Mhm.
And so thinking about those strategies, that's what comes to mind.
Great, thank you.
You're welcome.
Well, I'm afraid it is 1 o'clock. I would enjoy talking about this further, and I'm sure our audience would as well. But, Kimberly and Katie, thank you so much for this outstanding seminar, for all of the work that you're doing to improve care for older adults as well as their quality of life. So thank you so much for joining us today. As a reminder to participants, if you haven't completed the evaluation tool, it will be sent to you via email. So please complete that within a week, and then the contact hour certificates will be sent out within a month. Thanks again to everyone, and have a great rest of your day.